Is it echoing too much, or is that all right? It's all right now. Yeah. I'm Dr. Pratap Chandra. I'm one of the neonatologists and consultant pediatrician at Motherhood Hospital, Indranagar. So, Motherhood Hospitals India, we are hosting this workshop through the auspices of NNF India. So, I welcome all of you to this workshop. I know there is some small delay and small glitches, and I think from henceforth, I think we should just progress it very smoothly. Just before I start, I would like to get the audience attention here, and we can start with some introduction. And can we start from here?
Yeah. Good morning, all. I am Dr. Ram Prasad, the consultant neonatologist at Rainbow Children's Hospital, Vijayawada. I'm one of the faculty today, and I will be speaking on induction and management of hemodynamic management of hypothermia. All the best to Dr. Pratap. We have been doing therapeutic hypothermia for the past 6 years, and we have been using Tecotherm Neo servo mode, and we have presented a paper also of therapeutic hypothermia between started within 6 hours and after 6 to 12 hours also, that I will be discussing. So that's it.
Thank you.
Good morning, all. I am Dr. Ramanathan, practicing pediatrician from Sivagasi at Tamil Nadu. I have critical mission, everything, but I have to start yet hypothermia. Thank you.
Thank you, sir.
I am Dr. Rahul Kumar from Bihar, Patna, and I am participant. My center, Aradhya Child Care Center, and want to start. For that,
Hopefully, this workshop is going to be beneficial.
Hello, I'm Dr. Deepak, one of the faculty members. I work in Apollo as a neonatologist.
Good morning, everyone. This is Adarsh from IIT Ropar. I am a PhD student in the Department of Biomedical Engineering. My PhD thesis is related to neonatology. It is a kind of one milk dispensing system, one of the PhD thesis, and another one is the humidification and the oxygen therapy of neonatology.
Good morning, I am Dr. Kundan Kumar from Begusarai, Bihar, and I am doing neonatal cooling for last 1 year. And I'm learning more. I came here to learn more about this cooling therapy.
Brilliant, sir. Thank you for your enthusiasm. You're all postgraduates.
Good morning. I'm Dr. Milind from AJ Hospital, Mangalore. I'm a postgraduate there and come to learn more about HI therapy. We have the cooling system, but we have not used yet.
Good morning. This is Dr. Asif from AJ Institute of Medical Sciences. I'm second year postgraduate in AJ Institute. Dr. Santosh sir. Santosh sir.
Good morning, this is Swati. I'm a postgraduate in AJ Medical College. MD Pediatrics. Thank you.
Morning, everyone. I'm Dr. Swati Upadhyay. I'm assistant professor in neonatology at RML Hospital, Delhi. Yeah. So we have been cooling since last 3-4 years and using Tecotherm as well as Miracradle. We also have amplitude integrated EEG. So I have just come to have a brush up and revision.
Okay, thank you.
Thank you so much.
Good morning, everyone. This is Dr. Dhanlakshmi. I'm one of the neonatal consultant at Motherhood HRBR, and I'm one of the panelists today over here. And my experience with cooling is with motherhood as well, and also during my fellowship, we regularly cool babies, and also during my experience in Kerala, I also use Miracradle. So Miracradle and Criticool, both of it I've used.
Good morning, I'm Dr. Suresh Gowda, consultant neonatologist at Motherhood HRBR Hospital. Pretty good cooling experience abroad in UK as well, over a period of 10 years And following here at Motherhood, we've been cooling as well. In India, it's a pretty good experience over a period of 6 years, 2 years at Rainbow Children's Hospital, Marathalli, followed by 4.5 years at Motherhood, Indranagar unit.
Good morning. I'm Dr. Deepa Sharma from Motherhood Hospital, Indranagar, and today I'll be talking on cooling during transport. So yeah, we've been cooling for the last 5 years at Indranagar Motherhood, and we would be sharing our data during the talk. Yeah.
And rest of you are the people who've come from different organizations. I welcome all of you. Anybody who's not spoken?
I'm Dr. Rashikar Reddy, sir, from Nandyal SRFC, assistant professor there, just to brush up on it. No, sir.
Maybe you'll change your mind after this. Okay. Thanks everybody. So we will start our presentations from now on. Slide show, Kappa. And those who are virtually present, I'm so sorry, I cannot allow you to keep introducing because we can't see your faces. So welcome all of you. So today, I'm going to be talking on therapeutic hypothermia, overview, pathophysiology, and some of the referral pathways. I want to stress a little bit more on pathophysiology today. And there are a lot of other speakers who are talking. So wherever I think the other talks are there, I'm going to just skim through that. I'm not going to talk more in detail. Next slide. So yeah, overview, pathophysiology, and assessment. Next one. So we all know that anyway, I'm so sorry for these technical glitches. The delivery is supposed to be a very, very happy event. And, it is not a pathology. This is what we all need to understand. It's a physiological process. And it's a natural process. But we all know for various reasons, it's a very stressful event. Okay, just not for the mother. It's also for the babies. Not to forget even for the families. There are a lot of anticipation as well that goes with it. And a majority of the deliveries in India are still unattended. This is a situation which we all know to a greater extent. Even in bigger towns where we go and do these teachings and create awareness, still a lot of these nursing homes and hospitals, the pediatricians are not attending the deliveries. So whatever it has to be a happy moment may turn out to be a very stressful and tragic events for these babies. So luckily for us, 90% of these babies will make a very smooth transition into the neonatal life. And 10% of them will need some sort of an assistance. And again, we have to thank God that it's such a beautiful process. Only 1% of these babies who are born will need extensive resuscitation. But if you look at the population of India, that 1% is huge. Right? So still, therefore, the number of babies who are going to be affected will be very high compared to the babies that are born elsewhere in the other developed countries. So what can go wrong? There can be compromise. There can be compromise of the uterine and the placental blood flow, and this can result in deceleration of the fetal heart rate. Then you can have in utero hypoxia. There is infection, especially in the preterm babies. And meconium aspiration can happen, and all of these can lead to birth asphyxia. Then fetal hypoxemia, there is fetal bradycardia, there is systemic hypotension. There's so many things that can actually go wrong with these babies. And when we know that inside the womb, the baby's pulmonary artery hypertension is very high, and in some of these cases where they don't do a smooth transition, there can continue to have a persistent pulmonary hypertension. So these are some of the things that can go completely wrong. And if you look at the statistics, keep going. The neonatal encephalopathy, I'll come to that in a bit. What is neonatal encephalopathy? It's about 2 to 9 per 1,000 live births in the developed countries. And moderate to severe HIE in the developed countries, about 1 to 2 per 1,000 live births. But if you come to developing country, or how they are describing our nations as LMIC, the low and middle income countries, it can be as high as 60%. So in some of the states, it is very, very high. And like, I'm very glad there are people coming from Bihar to attend. In Bihar, it's also very high. It's very high in Rajasthan. So in those areas, so some of the areas are doing good, like Kerala. Even Goa is doing good in terms of the the HIE. And unfortunately for India, the HIE happens in the low socioeconomic strata, unlike the other conditions, right? And majority of these babies are unfortunately born in a very low resource setting areas, right? Resource is poor and patients cannot afford. So this is a very deadly combination, right? And when you look at it, India is such a vast country, the training and the resources are lacking. And majority, I'm sure some of these equipments, when you look at it, even when you want to treat, some of them are expensive, some of them are coming up with indigenously developed machines which can be a little cheaper. More and more people start using, then things can come down as well. So whatever you look at it, there is lack of training, there's lack of resources in such a vast country. It is not easy to do so. Next. So I want to drive home some of the terminologies that is very loosely used. People say perinatal hypoxia, ischemia, asphyxia as one entity. Some people say neonatal depression. What is it basically? Some people say neonatal encephalopathy. These have very clear guidelines and very clear definitions. Why is that important? One, you cannot just keep calling all babies which die as HIE, right? Because just because you've not investigated, those babies might have IEMs, okay? That is inborn errors of metabolism. And we are not checking it, right? So that doesn't mean you have to call it as HIE. And a lot of times what happens, the data will be very much skewed if you don't use the right terminologies, okay? So HIE is also common in babies who've got syndromes. Like for example, the aneuploidies, the Downs and the Patausen. These babies, they have high incidence of HIE when they're about to be born. So when you look at all these things, you cannot just put the label as birth asphyxia or label as HIE for everything, right? So let's just decipher that very quickly. Go on. So the perinatal events, most babies born with the low oxygen, whenever the babies are going to be delivered, they are born with little bit of low oxygen. They're in a hypoxic state. And there is a decreased blood flow to the placenta. Why? There are uterine contractions, cord compression, maternal dehydration which happens. Also they are panting quite a bit, and therefore the CO2 levels come down, which can result in alkalosis. All these events result in decreased blood flow. Next. And reduced placental flow, which means the baby is also getting reduced blood supply. And during these stressful times, there is increased oxygen consumption as well, both for the baby as well as the mother. Okay. Then what happens if these babies are born and if they have experienced brief asphyxia during the time of uterine contractions and while they're coming out during these stressful events, there is initial increase in the heart rate very quickly, but then it starts dipping down. Okay. Next. And initially there will be increase in the blood pressure. Again, it will start dipping down, and then the central venous pressure will also start dipping down. This is all happening in the babies. When these things happen, there will be a redistribution of the cardiac output, because the body thinks, the most important organs should start getting the blood supply, right? And what sets in is called a diving reflex, where three most important organs, the brain, the heart, and the adrenals. So these will start getting better blood supply, and the rest of the areas and rest of the organs will not receive those sort of blood supply. And if it is severe and if it's very brief, the blood flow diversion is hampered to the deeper nuclear structures. So if you look at the brain model, if you can imagine, the central areas where your nuclei are present, where your thalami are present, where your internal capsule is present. So those are the areas which will have end arteries. And these are the areas which immediately the blood supply will stop. right? So therefore, in a very brief asphyxia or the hypoxic event, the area that is going to be damaged is the deeper nuclear structures, which is subcortical and also the brainstem, right? Imagine if the brainstem is affected. Can anyone tell me the function of the brainstem from the postgraduates? If the brainstem is affected, can we breathe? No. So the respiratory system, respiratory centers are located in there. So what happens, therefore, if the baby has not received the blood supply, it's not going to breathe. It's not going to cry, right? So this will result in further hampering of the hypoxia within the brain, right? Although the diving reflex is there, everything is diverted to the brain, wherever the end arteries are there, that's going to suffer. And these are all in the subcortical and in the brainstem areas. So typically, a brief HIE insult will result in areas that are damaged, which are in the subcortical areas, not the cortex, right? So as opposed to, next, if you look at it, if the hypoxia is little prolonged, right? So mothers come in with loss of fetal movements, 4 hours, 6 hours, or the CTG is abnormal. You're not able to take them for the section for a little longer time. Then what happens? All this loss of the pressure regulation and CO2 vasoreactivity. What we say is, whenever the CO2 is built up, basically the babies will start breathing. If people are using the ventilators, you all know, you don't want to hyperventilate these babies. Why do you not want to do it? The critical value of CO2, if you're using it in the cm centimeters of water, is less than 30. Less than 30, if your CO2 is going, then the blood supply will decrease. If it's less than 25, your CO2 values, the PaCO2 values, then almost no blood goes into the brain. It just gets into that sort of a position where your blood supply is completely hampered. Therefore, in extreme preterm babies, this physiology is important because it causes, anybody? Low CO2 in preterm babies causes what? No, sir. Opposite. It causes PVL. PVL, because there's no blood supply there. So on the contrary, if the CO2 is very high, you're not ventilating properly, or if you have a bad pneumothorax, your CO2 has drastically shot up, then that results in increased blood flow to the brain. That causes IVH, right? So low blood supply, PVL. Very high blood supply is IVH. So this results in continued hypotension, and obviously with that hypotension, decreased cardiac output. Can anyone tell me what is the cardiac output? Heart rate times stroke volume into the heart rate. So when there is loss of the blood pressure, the blood which is going back to the heart is suffered, right? So therefore your stroke volume is gone. Therefore, what happens? The heart, the first thing it does is it increases the heart rate, so that it needs to compensate. After some time, if this insult is continued, started anyway. So anything that you didn't understand what we were discussing? Any questions in here? Ready? No? Okay, great. Start up. All right, so we mentioned criteria A, which is the condition of the baby at birth. Criteria B is going to be your clinical examination. So if any baby meets that, you should start active cooling or refer to the cooling center, right? And if it doesn't meet the criteria, obviously standard intensive care should be given to these babies. So other people are not going to talk about this in much. Supportive therapies, this is based on our experience. You know, the cooling you have started, I'm not going to go in much detail of that because there are other speakers on that. So when you look at the ventilation, majority with moderate to severe will need some sort of a support, whether they need an HFNC or usually we don't give CPAP to bigger babies, you know, they fight quite a lot. And, you know, whether they need, if they've got a lot of seizures, you know, they might need ventilation. And if you use a lot of phenobarbital, levetiracetam, they need that sort of a ventilation support. And in babies who are associated with meconium aspiration also, they might need gentilation, we call it, gentle ventilation, which is provided by your high frequency oscillation. So sometimes you may have to use that. Sometimes if these babies develop pulmonary hypertension, or if they develop pneumothorax secondary to your meconium aspiration, on top of your cooling and stuff. So you need a place where they've got inhaled nitric oxide available. Otherwise, you know, your therapy is never effective. You have to have everything with you. That is the reason why NNF is suggesting that cooling should be done in places where all these facilities are available. And always aim for near normal CO2 and pH. They say towards alkalosis, but then I think normalcy is much better always. All these babies, don't forget that they are acidotic. Okay, whenever they're acidotic, they breathe heavily. Then the CO2 levels come down, right? When the CO2 levels come down, obviously we discussed, the brain doesn't get the blood supply. So the ischemic process gets worsen and worsen. So you have to aim for normal CO2s. And in sometimes we may have to even give sedation. Sometimes we have to paralyze, especially if they have associated PPHN and all that. So in those cases, you will not know what is happening neurologically. That is where amplitude EEG comes into help, right? And yeah, consider sedation process. Next. Coming to your circulation, Gopa, circulation. So one of the things people do whenever they see acidosis, it's a knee-jerk reaction to keep giving boluses and boluses. You know, I've seen babies receiving 40 ml per kg, 50 ml per kg. Don't do that. These babies did not have a volume loss. That's one thing you have to be careful. No volume loss. Yeah, it may be abruption. In abruption, again, majority is the maternal loss, not the fetal loss. So volume loss may not be there. The main reason for your acidosis is your buildup of the lactate, and therefore it is hypoxia. So once you start correcting your hypoxia, the acidosis will gradually get better. Don't aim to correct your acidosis and be in a very jittery mode to do that in the next 2 to 3 hours. You cannot do it. If you do it, it will only worsen. Don't keep giving bicarbonate. There's no role for that. There is a role in some cases in whenever you're using very inotropes, adrenaline, noradrenaline, things like that, then you need a little bit of alkalinity for that drug to work really well. But otherwise, majority of the times you should never use sodium bicarbonate also. And you're trying to here avoid the cerebral edema. So as I said, whenever the insult is there, the calcium influx, the water influx will also happen, and the cells will start swelling up, right? Cerebral edema is the main reason why you get the seizures. You get seizures because either there is a stroke-like an event which has happened, or there is a cerebral edema, right? Once you start controlling the edema, you see majority of people who are cooling, you know, day 3, day 4, your seizures will stop, even in the severest of ones. You know, if it is going more than that, then you're thinking of alternative diagnosis also, right? Or it's very, very severe HIE. And then, you know, we tend to restrict the fluid to 40 ml per kg. One is for the brain, and the other one is for your kidneys, right? In AKI, you restrict your fluid to 40 ml per kg, plus you take out the losses, the urine output of the previous day, and you start adding that if needed. Otherwise, keep it at 40 ml per kg. And adequate blood pressure should be maintained, because PPHN already is common. Hypothermia induces pulmonary hypertension. So you need to have a good blood pressure to not allow the baby to go back to that. And watch for renal improvement. The second, third day, the renal shutdown will have happened on the first day. You might get oliguria, in some cases anuria as well. And what we have experienced is, if it's going towards anuria, give one fluid challenge with furosemide. That will kickstart your kidneys. Once it kickstarts, it enters next stage is your diuretic phase. Then they will pee like it's nobody's business. So that is when you need to alter the fluid management, right? So that's all I wanted to talk about 2 systems. Practically, you need to be aware of the sentinel events. Keep going. And inform the cooling center ASAP and seek advice, because you have to probably document in your center also that you've spoken to these people, we have discussed, it's not meeting the criteria, therefore I'm not cooling. Okay? Just 4 years ago in our center, before we started, there was a gynec who was sued for 1.5 CR because she did not refer for cooling. At that time, our center did not have that. After we came in, we started. But luckily, I was one of the ones who gave the opinions for her for this court thing. Luckily, the baby was 34 weeks. So imagine all our savings, all our lifetime earning, everything will go off. So please also have a good indemnity also. And always take informed and consent before starting even passive cooling or active cooling. Okay? Whenever you've cooled, people who have done cooling, we all know that there's a severe vasoconstriction. Therefore, you cannot do the peripheral lines that well. Either do it before starting cooling, or always have UVC or a PICC line. Okay? Why is it important? Because I said these babies might be very sick. Other organs are also damaged, no? So brain is damaged means other organs are also damaged. So you might need inotropic support. So inotropes never give peripheral. Only one is allowed for temporary purpose, which is dobutamine, maybe at 5 mics. Rest of it has to go central. You're cooling, and if you have given NARED in the periphery, your hand will break. So be careful, don't do that. Always get a central line before cooling stuff. And consider multi-organ involvement. Go. Usually, servo-controlled cooling achieves much better, normothermia, but then when people are talking, they also talk about the phase-changing materials, and there are a lot of other machines that is coming. We'll see how it goes. In summary, neonatal encephalopathy or HIE is very common in India. It's much commoner than the developed countries. Therapeutic hypothermia is, it's considered safe, and it shows that it has worked in developed countries. We have had only one trial, which is the Helix trial, which is a multi-center, multinational trial in the LMIC countries. But again, Mangal Bharti will talk about that. And it is a standard of care in the West, which means if you don't give oxygen for a baby who's hypoxic, you are liable in the court of law. It's very simple, right? Because everybody knows you have to give oxygen for a baby who's not saturating well. Similarly, if the baby meets the criteria, you should cool. This is the standard of care in the West. If you don't cool, then you're liable for persecution, right? Next. And in India, it will soon catch up. NNF has already suggested that you should do it in the level 3 center. That means if you have not referred or if you have not cooled, then people who are well versed in this, always remember, delivery is a very happy moment. When something goes wrong, all the relatives are there with them. They keep pestering them. These people have done something wrong. So your documentation, communication, everything should be very, very precise, right? Passive cooling may be undertaken. Some other person will discuss that before the team reaches the cooling center, because the therapeutic window is about 6 hours. And servo control cooling usually achieves better thermal control. HIE definitely should be managed in a well-equipped NICU. Okay, keep going. Okay, it's an emergency, and there's a very limited therapeutic window. Thank you very much. I think I've given a brief overview of the whole things. Now I think as we go on to the subsequent, subsequent talks, I think you'll have a better in-depth knowledge of each one of the systems and things. So without further delay, if Dr. Mangal Bharti is already there, how do I know he's there? Now it's disconnected. Connection hoita? Yes, you are audible. Yes, yes, you are. Okay, start, please. Yes, please.
My apologies for not being able to be there physically. I hope that we'll be able to discuss two points related to the we had, I think, Dr. Pradap has given a wonderful outline of including the various practical aspects of schooling to all of you. So I'll be trying to focus a little bit on and what we have learned from this trial and whether this trial will change our practice related to cooling or therapeutic hypothermia. And so, greetings from my institution, Department of Neonatology, Madras Medical College. So our unit has got two separate units. One is a pure extramural unit catering to babies who are getting referred from other hospitals. And the other is an intramural wing which is attached with the obstetric unit, which caters to a delivery load of around 16,000 to 18,000 deliveries per year. So both these centers were part of this trial, the intramural unit as well as the extramural unit. Quite sure that most of you would have had a chance to look at this paper published in September in the Lancet Global. So the HELIX stands for hypothermia for moderate or severe encephalopathy in low-income and middle-income countries. The randomized controlled trial done in 3 countries, India, Sri Lanka, and Bangladesh. So what I intend to do is, even if you have not read these papers, no worries. So I'll be just highlighting the most important aspects of this paper quickly. Then maybe we'll spend some time on so what do we learn from the results of this trial. Where did we start actually? Our unit initially started even before this HELIX trial. We started with evaluation of a low-cost cooling device which people are trying to make. So that machine actually was called as a HELIX Picotherm. We all know that Picotherm is one of a leader in servo-controlled cooling devices. But there are many servo-controlled cooling devices. Picotherm is one of them. Most of these devices are very expensive devices. And but servo-controlled devices are considered as the gold standard to provide cooling. Though in India we do have a lot of other modes, especially based on phase-changing material like the Mera Travel ones. So there was an intention and attempt to manufacture a servo-controlled device which will be very cheap and which will have a larger applications in low and middle income countries. So that is where we started. Again, this was just a feasibility of a whole body cooling using a low cost servo control device. And so this is how that device looked actually. It's a very, very compact device compared to Picotherm. And it's just a trimmed down version of the Picotherm, which I should say. So the various different modes were taken away. So it had only one mode, which is just like if you switch it on, it will just attempt cooling at 33.5 degrees centigrade, one fixed temperature, no different modes, no different temperatures. But it is the same mechanisms. It's a mattress based coolant is circulated through the mattress And there is a rectal probe which monitors the temperature. And the device did not have actually a rewarming part. The rewarming part was done manually when initially. That part was later added as an option to this device. But initially when we tested, it was not capable of rewarming the patients. But we had very good results. So this is a chart showing what is the mean temperature that is maintained for the period of 72 hours which we are cooling. So in a short time, actually, there was a good induction. Say, within an hour or two, most of the babies reached the target temperature of 33.5 degrees centigrade. And there was no major fluctuations. So throughout the 72 hours period of cooling, the temperature was well maintained around 33.5 degree using this device as well. And then, so this was more passive rewarming, the temperature back to 36.5 degree. So this, the end result of the study was the device was reliable. It was, and it's a valid tool which can be used for cooling babies. And but we analyzed certain clinical factors also during this trial. This was, as it was a trial only to test the feasibility of a new equipment. It was not a randomized trial. We were not randomizing babies to cooling at that point of time. So just there were some babies who were put on this device, and there were some who were not cooled. And when we looked at their clinical outcomes, actually that was not the intention of this trial, but still we didn't find a significant difference in mortality at that point of time. In fact, our cooling arm had less mortality as far as this trial is concerned, babies who were cooled. But whoever had died, again, we found a very high incidence of bleeding, especially a gastric bleeding. And that was reported in this paper. If we just look into these numbers, so babies who did not have a bleed hardly had any mortality, whereas those babies who had a bleed had a very high mortality going up to 44%. You know, it was surprising because the gastric bleeding was hardly reported from the Western countries as an adverse event of cooling. It looked our babies were totally different, so we reported that one. This paved this initial trial, which we are part of, paved the way for the proper multicentric large randomized controlled trial to evaluate really whether
recording in progress.
So I think Dr. Pratap would have discussed this NACHT neurological examination. It's just a modification of the Sarnath scoring system, but it has been made more objective. Whereas actually you just see there are various signs listed. People had to make circles. So in fact, every categories of these 6 categories, whenever baby is there, we need to just make circles. And then we just count the circles at the end to see that where most of the circles were. Wherever we have 3 or more circles, that will be the classification. Reasonably, I'll say, an objective way. And just to improve the objectivity, actually the scoring was done by 2 different persons. Only when they both agreed on the level of HAE, whether it is mild, moderate, or severe. So that was taken as the final report. If they differ, then senior was involved in the assessment of the level of oxygen. Who did we exclude? The babies who are more likely to die, like asthma, heart rate. Please, others can you mute us? Babies with major life-threatening malformations. And as it was a trial which warranted an 18 months follow-up for measuring neurodevelopmental outcomes. So whoever is unlikely to come back for follow-up, like migrant family or parents, they were also excluded from the trial. And the primary outcome measure was to measure, it was a combined outcome. We were interested in measuring death or having some form of moderate or severe neurodevelopmental disability. So what are the incidence between these 2 groups? That was the primary outcome measure. So this was the initial estimation done. So when we started the trial, our hypothesis was cooling will decrease the primary endpoint, that is mortality or moderate to severe neurodevelopmental disability. So based on trials from the West, so we thought that it can lead to something like a 30% relative reduction in the primary outcome. So the baseline estimated was around 50, so we thought it can go up to 35 to achieve that with the standard alpha and beta values, giving an allowance of a 10% loss to follow up. So we required around 204 babies in each group for this trial. So again, I won't be boring you with all these numbers. So this is the process that was followed, and showing, we approached something close to around more than 2,300 babies, and then we found around 576 to be eligible, but around 67 distinct. And 206 babies in each of the limbs, the intervention limb and the control group. Though we had given an allowance for a 10% loss to follow up, there was a very good follow-up rate. Hardly we didn't even have an 5% of the loss to follow. So only 7 babies did not have the primary endpoint available in both the limbs out of more than 200 babies. Even after the 7, around 3 and 2 were available for their assessment over telephone. Only 4 and 5 were lost to follow up. So we had a reasonably very good number of 195 in the intervention limb and 199 in the control limb who were assessed for the primary endpoint, which is the combined outcome of death and 18 months neurodevelopmental outcome. Okay, this is the final very important slide. So what had happened to the primary outcome? If you look into this composite primary outcome, death or disability, there was no difference between the two groups. Just see 50% incidence in the hypothermia group and 47%. So the p-value was not significant, RR going on both sides of 1. So saying that actually cooling did not make any difference in the primary outcome. What was surprising, or say rather than surprising, what was worrisome was, so one of a very important secondary outcome. So that is when we measure the death up to 18 months. So we had around 42% deaths happening in the cooling limb, whereas the death incidence was around 31% in the control limb. Very significant difference with a risk ratio of 1.35, both lying on the confidence intervals, lying more than 1. Whereas the difference was noticed in the disability. Of course, the reverse was true. As there were more deaths, we find less babies with disability in the hypothermia limb, and more babies had disability in the control group. So these are the major findings. I think again we will just stick to them for the time being. I'll skip the other. I just kept the table only if somebody had any questions to answer that. I kept the table. As we found in the initial pilot trial, then looking into the causes why the babies died, why was the mortality high? So you can just see the main differences were babies in the cooling limb had high incidence of gastric bleed. Pulmonary hemorrhage incidence was quite high. The incidence of PPHN was a little high in them. They had abnormal coagulation. The sepsis rate was not different between them. And thrombocytopenia was significantly different metabolic acidosis. They were sick babies. Shock, poor perfusion, abnormal coagulation, thrombocytopenia, gastric bleeding, and pulmonary bleeding. These were the main differences between the groups who were cooled and not cooled. And they seem to be the important events causing more deaths in the hypothermia group. So this is a slide showing actually what was the grade of encephalopathy. The grade of encephalopathy was daily measured for a week's time in both the groups, intervention and control. So babies moved from HAE 3 to 2, and even they moved to mild encephalopathy in both the limbs. But this is expected. I think there was no difference between the two groups related to the proportion of babies and how these babies moved, whether the improvement in their encephalopathy from severe to moderate or mild over a period of time. That was the same between the two groups. And was there a difference? Was this result due to very poorly maintained or poorly administered cooling? No, definitely very clear data from all the babies showing a very tightly regulated and maintained temperature throughout at 33.5 degrees centigrade, and a very controlled way of rewarming also. And babies, and there was a lot of measures taken in the control group also to avoid hyperthermia. So hardly any babies in the control limb had temperatures reaching hyperthermia as well. So this is a survival graph showing that the blue is the full limb. So there was a very significant difference in terms of survival, less survival in the cooling, which continued till 18 months when we measured. The difference between the two is there throughout. There was an analysis of MRI biomarkers also between the two groups. This is a little complex, so I'll just say that the biomarkers which estimate both the injury as well as the recovery, they were the same in the both groups. There was no significant difference when we look into the biomarkers between the cooling group and the non-cooling group. Okay, and a very significant proportion of babies had seizures. So around more than in both the groups, cooling and non-cooled, close to 70% babies had seizures at the time of randomization itself, and around 15% had seizures on day one out of the babies who had seizures. So that was a bit surprising, very early onset of seizures. And but there was a significant drop in the heart rate again, which proves that cooling was effective in the intervention. Okay, I think that's enough related to the data. So again, in nutshell, almost the inclusion and exclusion criteria of this trial was a very standard in lines of the other cooling trials that have been done. There was a very big sample size, more than 200 babies in each limb, and all babies were assessed objectively. The inclusion was based upon NACHT classification to assess the level of encephalopathy, and we did not use the modified device for this trial. This was the actual tachothumb as far as the helix trial is concerned. And all babies were under continuous rectal monitoring throughout. And we had access to 3T MRI also in all these centers. 2 centers from Chennai, 1 from Bangalore, 1 each from Mumbai and Trivandrum. These are the 5 centers in India, and 1 center from Bangladesh and Sri Lanka. So we went back and we did some subgroup analysis also to see, to understand, so what are the likely causes? So one thing was very clear. Rewarming, both phases. So then comes the question, is it related to the setting or the population differences? Are these babies in the low and middle income settings inherently different, or the kind of population which are coming to these, because all these hospitals are public sector hospitals, no private sector hospitals were involved. Is it because of the kind of babies which are being referred to the public sector hospitals? So these were the questions in mind. So again, just quickly going through, stratifying the results by whether was there a difference between inborn babies and outborn babies. Most of our babies were outborn babies, nearly 60%. Only around 40% of the babies were inborn. So the trend was the same, even though inborn, the results became insignificant when we just looked into the inborn group itself, but the trend was more like an increased risk of mortality, both in inborn and in outborn babies. There's no difference when we try to stratify by the birth weight on the result, almost all staying on one side. Going by the growth status, we had around 25% of small for gestational age babies. SGA was not an exclusion criteria, but still both AGA and SGA seem to have the same effect. It was not an influencing factor. Many people question whether it is because of an increased incidence of sepsis, because in public sector hospitals, the incidence of sepsis could be quite high. Again, when you stratify by presence or absence of sepsis, the results did not differ. And this is a very important slide. See, this is actually, even though this number is alarmingly different from what we see in the Western world, like only 11.5% of our total babies had some documented perinatal sentinel event. No sentinel event was documented in 88.5% of the babies. But that is even, leave the trial. So whenever we have asphyxias getting reported, babies getting referred from outbound units, hardly there is any documented asphyxia, sentinel event. But that is the usual kind of babies that we get, irrespective of whether it is Chennai, Bangalore, Mumbai, or Trivandrum. So that also, we're not sure whether it influenced the outcome. And stratifying by the center or the center's death rates did not make any difference. The same was found in the other when the composite outcome was also looked at. So coming to final few slides, okay. So we concluded based upon our analysis, look like at least going by the various subgroup analysis did not yield any difference in the results. So it looks like cooling is not safe in the babies who are included in the trials. It increases to more mortality. So we suggested that people should be cautious, and it is not safe to do cooling in babies in low and middle.
Mangal Bharti, can you hear us talking?
No significant difference as far as our trial is concerned. The data was shown in the form of a graph.
Mangal, can you hear us now? Okay, so we have a little technical glitch here. We can't hear your voice in the speakers. All our people present here, we couldn't hear the final conclusion aspect of it. Can you just very briefly tell us the conclusions?
I'm sorry for the technical glitch. So the nutshell of the presentation was, see, this trial, the HELIX trial, was a well-conducted, adequately numbered, and well-executed trial, quality control trial, but done mainly in public sector hospitals from India, Bangladesh, and Sri Lanka. So what we found is that actually the cooling doesn't make any difference in the combined outcome of death or neurodevelopmental disability at 18 months, and it leads to more deaths in the cooling limb. So that is a concern. That's why the trial concluded saying that cooling seems to be leading to more mortality, and we should do away from cooling in babies in LMICs. Definitely the settings in the public health setting and the private settings might be different. The kind of babies, as it showed in the data, like these are babies who are 60% of them are outborn, and only nearly 11% of these babies had a sentinel event documented. Around 88+% of babies did not have any sentinel event documented there. But I'll say, to my knowledge and going by my experience, so these are the kind of babies what we see day in and day out in a public health hospitals, which might be, a rough estimation, maybe something like more than 80% of the asphyxia and the HAE load what we see. So these centers should be very, very careful. They should not, they can't undermine or take these results from HELIX easily. The rest of around 15 to 20% of the babies who are being cooled in the private sectors, again, the onus is now on these centers to just collate data in the form of a registry and to show that really actually the cooling is safe and it brings, and maybe the population is different. So till that time, I think the NNF has done a wonderful job and coming out with a question statement. Now NNF has brought in very rigorous criteria, like babies, NNF is recommending cooling only apart from the standard guidelines, like more than 36 weeks, less than 6 hours of life. These babies should not have hypo or hyperthermia on admission. The temperature should be 36 to 37.5. There should be a cot gas available or a gas in the first hour of life where the pH should be documented to be less than 7 or base X is more than -16. And there should be a documented sentinel event with moderate or severe. This is the criteria given by NNF expert committee right now. So I'll say if your baby fits in with all, which may not be the case in many babies with HAE, only in this group, NNF had gone ahead recommending. The other group, definitely there is a concern whether cooling can lead to more deaths. That's my final.
Just quickly, Mangal Bharti, I know the position statement, but in your center, have you stopped cooling or are you continuing?
Our kind of babies are the same, whatever we had in the trial, or the babies whom we continue to get even today. We are just looking at our sentinel events data, which is hardly 10 to 15%. We don't get as a documented sentinel event in 80% of the babies. And still we continue to receive babies with not properly documented ABGARs in our outbound unit. It is written as asphyxia, baby not cried, some resuscitation done. We don't have properly documented ABGARs and it will serve resuscitation. So in both our intra and extramural centers, right now we are not cooling.
Thank you. One last question. I don't know whether audience have got any other questions. Anybody else have got a question? So one last question from me is about this Pondicherry study on the genetics of the Asian babies and why they are hypothesizing that this could be the possible reasons why HELIX trial showed such bad outcomes.
Yeah, I do agree that actually I don't question or their findings or observations. The only concerns are that actually, the numbers are small in the other trials, and maybe they had catered to different kinds of babies because all their data was on intramural babies. They did not have any extramural babies. So that's why I'm just repeatedly saying that it is time for us to find out whether we do have to find out a subgroup which is going to be beneficial and whether it can be dangerous in the other group. So that is where we are right now. to identify or find out in which subgroup it might be working and which group it may not be working. The main concern is that most of the babies in India right now, especially coming to public sector hospital, will fall in the group what we had in the Helix trial. That is the major concern. That's why we are not started cooling, sir.
Okay, thank you so much, Dr. Mangal Bharti, for clear explanation on the Helix trial. And thank you so much for joining. We will move on without further delay. And then the next topic is about induction and maintenance of hypothermia, hemodynamic monitoring, blood investigations, and it's a long, long talk from Dr. Ram Prasad.
Yeah, very good morning. So, for all practical purposes, since this is therapeutic hypothermia and therapeutic hypothermia workshop, we believe in that one. Let's all keep Helix a little bit away, and we believe that therapeutic hypothermia works, and we'll go forward today, and let's see what happens. So, So most of the centers where Sir has started, and recently a few pediatricians have started this one. Have you found any sort of problems in managing ventilation or circulation? So therapeutic hypothermia is the specific management, but supportive management is also very important. Have you found any difficulties, sir, in pardon? Not yet started. Anybody was? Yeah, madam.
Babies are cool, so it's very difficult to palpate the peripheral pulses. CFT is always prolonged, and they always remain cold. So unless and until we have invasive blood pressure monitoring, it becomes very difficult to even identify shock, and that is why shock goes unidentified many times. So that worsens the outcomes.
Exactly, that's what Dr. Pratap was telling, that it has to be in level 3 where invasive blood pressure monitoring has to be there when you're monitoring such a sick child. Invasive blood pressure monitoring, of course, functional echocardiography is also a very useful tool for managing or assessing the sickness of the such child. So this was the Tacotherm Neo, what we use for cooling babies who have entered the cooling criteria. We use these machines for almost 72 hours and rewarm for next 12 hours. Next slide. So till today, we all thought that it's a static encephalopathy, but in fact it's a progressive. The tertial damage can continue for years after that. But here is the thing where we are going to introduce, before the reperfusion injury starts, between the primary energy failure and secondary energy failure, where Dr. Pratap was telling, it is a 6 hours period where it is there, where we have to start before that secondary injury sets in. We have to start to prevent the progress of brain injury. Next. So this therapeutic window of opportunity is very important, so that if you see or if you found any HI baby at centers, that passive cooling, or that madam is going to talk, plays very important role, because it will take at least a good half an hour to 1 hour to get the temperature from 36.5 to 33.5. So it's better, because we have to start. Most of the studies have told that it is beneficial if you start within less than 6 hours. So if the child baby reaches around 5 hours, 5.5 hours, it may take for transport. So if the baby is already on passive transport, passive cooling, it will give a good result, rather than getting the baby after 6 hours and we'll start cooling. It will take at least 1 hour. So next. So usually we will be talking about Sarnath's and Sarnath cooling system, but one or more easier is leave-in classification. We see consciousness, tone, seizures, sucking, and respiration. It's a simplified classification of Sarnath and Sarnath, where it classifies into mild, moderate, and severe. It is just introduction of what I mean. So consciousness, a mild child, mild HIE, child will be irritable. Moderate and severe, it will be comatose. Tone, hypo, hypotonic and mild, and marked hypotonia and severe HIE. Of course, entry of seizures will be there with the moderate HIE, and sucking, poor suck to unable to sustain respiration, or apneas can occur in severe HIE. So video play out. No, just it's always better to have audio visual clues when it's playing. Not playing. put one video, but unfortunately. Okay, no problem. We'll go to next slide. So, coming to the actual topic, induction management of hypothermia. So, it's always specific treatment. Hypothermia is very important. Apart from that, supportive management is very, very, very crucial for getting the benefits out of hypothermia. Now, we are thinking hypothermia along with other adjuvant drugs like erythropoietin, all we are talking about now. But if you can properly manage the child with properly ventilate, properly manage circulation, if you can maintain the brain perfusion properly for the first 3 days after a HI injury, along with therapeutic hypothermia, most of the studies have shown that it will yield a good neurological outcome. So it's very important to maintain hemodynamic. See, hemodynamic monitoring is very, very crucial, important as therapeutic hypothermia. You cannot underestimate the supportive management. So prevention, of course, is the key to success. Ensure physiological oxygen acid base balance, correct fluid electrolyte disturbances, avoid hypoglycemias and hyperglycemias, both are injurious to brain. Maintain adequate volume and hemostasis. Shall we smile at them? So usually hypothermia induction, when we have any of the servo control machines or phase contrast material, as soon as we receive the baby, we will start doing keeping the baby under, as long as we will get the transport call also, we have to make sure that we will get ready this all servo control machine ready, because it's little bit process will be there to fill up the sheets, and you have to make sure that everything is ready. And as soon as baby reaches here, we have to start the induction phase. The induction is nothing but, so induction, maintenance and rewarming phase will be there in hypothermia. So how does induction work? So specific cooling is started within the first 6 hours of life. Battery is there. So Tecotherm Neo and Miracradle. Yeah, it's working. Where should I show? I think it's working only with the laptop. It's not working with the. No, it's working here. Okay, it's okay. It's okay. So it started within 6 hours. We all know, but few centers will see up to 12 hours also they are taking, but as soon as now the studies are there till 6 hours it's beneficial. 6 to 12 is still controversy. After 12 hours you don't cool the babies usually, because already secondary injury has set in. So it's very important to start within 6 hours, maintain for 72 hours at 33 to 33.5, and it's the only proven neuroprotective. It's the only specific treatment for decreasing the brain damage. So what you have to remember is hypoxic ischemic encephalopathy, asphyxia, affects each and every organ of the body. It's not only the brain, it affects the heart, it affects the lungs, it affects the liver, kidneys, blood, everything is affected with this hypoxemia. So you have to take care of entire system, not only the brain. So of course, when to start cooling? As soon as possible after resuscitation is completed. If you have in-house baby, as soon as it has started, you resuscitated the baby. Make sure that resuscitation you do with room air initially, because we all know hyperoxia is bad to the lungs, is bad to the brain, bad to each and every organ of the body, because it induces free radical injury. So during resuscitation, make sure that you start with room air. But if you require, as per NRP guidelines, if you require chest compressions in term baby, then only you will increase your FiO2 to 100%. Otherwise, you can resuscitate with room air, because the studies have shown that those babies who have resuscitated with room air, their neurological outcomes is more good when compared to started with oxygen. Current evidence that cooling is unlikely to start with, after 6 to 8 hours. So these criteria, I think Dr. Pratap has already described all this what are the contraindications for cooling. Yeah, passive cooling, as I said, it's very important to start cooling the baby during the transport itself, so that baby when reaches here, we will do start cooling in the programmed fashion, because passive cooling should be initiated as soon as potentially eligible neonate is identified. You have a sentinel event, baby hasn't cried, or baby is having history of blood loss like antepartum hemorrhage or any cord prolapse. So immediately after getting the baby to the warmer, just switch off the warmer and make sure the temperature doesn't go up. So switching off warmer is one of the things what we can do in our in-house. Then we can shift to the, if cooling is available, you can shift to the servo control, this one. So this is a protocol usually for cooling, passive cooling the babies. So what they will do is, usually they will decrease the temperature. They will not put any warmer. They will get the temperature to 33, 33.5. If the temperature is going below 33.5, they will wrap up the blankets. If it's more than 34 or 35, they will open the blankets. That's how they will come for the passive cooling. So this is the actual, this one induction phase starts at, I mean, it will take good 1 hour, half an hour to 1 hour for this phase 1. Then beginning of the maintenance phase, phase 2, and then the rewarming phase, which will take at least 12 hours, 0.5 degrees per hour, we have to rewarm. So that's what rewarming should be done slowly. Now, there is one problem with rewarming is, if you do fast rewarming, child may again throw seizures. So if you find seizures during rewarming phase, you get down the temperature again to the phase where baby is stable. For example, if it is 35.5, baby is getting, or 36, baby is getting seizures, go back to 35.5 or 35 again for few hours, then we have to rewarm. That's how we can control seizures. So there is increased risk of seizures during rewarming. Consider EEG, whenever we have to do EEG monitoring, either amplitude EEG or, if not available, 12-lead ECG. Now this Thompson score, what we routinely follow for any baby who is on total body cooling. So we'll regularly record every day for the first 2 to 4 days of the birth to know the neurological outcome. A score of more than 12 is associated with adverse outcomes. We see how is the tone, level of consciousness, seizures are there, posture, Moro's, grasp, reflex, other reflexes, respiration, and fontanelle. If you follow this Thompson score daily, once we can, when the child is on total body cooling, then we can see how the neurological outcome be. So as I said, more than 12 is associated with adverse outcomes. Now, coming to the hemodynamic, this one, respiration. Few points have already Dr. Pratap has told regarding the importance of hyperoxia and hypocarbia. Now, it's very important that you maintain your oxygen status and carbon dioxide at a very normal level, not less than or more than the normal levels, because both are bad to the brain. What happens? Asphyxia itself can associate with apnea, pulmonary hypertension, meconium aspiration, RDS, pulmonary hemorrhage. They will affect the lungs. In contrast, you are doing therapeutic hypothermia. What does therapeutic hypothermia do? It will decrease the oxygen consumption in parallel with the carbon dioxide production also, increase the minute ventilation, and of course increase surfactant activity. All this will affect the lungs functioning also in the form of hyperoxia, increasing the oxygen levels, and hypocarbia. So what happens with hypocarbia? What does Dr. Pratap tell? Hypocarbia causes? What does hypocarbia do? Postgraduates? Vasoconstriction, thereby decreasing the blood supply to the brain. So usually, initially child might become after asphyxia, the CO2 levels may be high, carbon dioxide levels may be high because maybe apnea, all these things. But after that, child will have hypocapnia. Why child will have hypocapnia? Because one is they will have increased metabolic acidosis, which can cause acidotic breathing, that can cause hypocapnia. Second one is when you start on therapeutic hypothermia, there is decreased incidence of carbon dioxide production, which can cause hypocapnia. So hypocapnia, what does it do? It will cause, one thing is decreased blood supply to the brain, leading to what are the oxygen delivery system, decrease oxygen delivery is also impaired. At the same time, extraction is also impaired. So blood flow is decreased means oxygen delivery to the brain is decreased. So it is important that hypocarbia should be avoided. Second thing is not only it decrease the blood supply, it increases the neuronal excitability and it augments the apoptic cell death. So it's very important that you prevent hypocarbia. Why I'm stressing this point is, you will come to the ventilation next. During ventilation, our main goal is to maintain our oxygen and carbon dioxide levels in the normal levels. That's why it's very important that you have to sit beside the child and monitor your carbon dioxide levels. And again, hyperoxia. What does hyperoxia cause? We already seen. Hyperoxia causes free radical injury. It causes to the free radical injury to the brain. So we should avoid. It causes oxidative stress and increase in the inflammatory mediators, free radical injury. That's how it causes bad to the brain and other organ systems. So that's why it's very important to maintain normal oxygen levels and normal carbon. What is a normal? Let's see. So this is a study, it's an article which is published recently, respiratory management during therapeutic hypothermia for HIE, where it shows that infants who require the ventilator requirements, ABG should be monitored at least 4 to 6 hours initially, because the PCO2 should be managed within 38 to 45. Now, doing ABG, there is a little bit of one clinical point is that all the ABG machines measure the POCO2, PO2 derived values at temperature of 37 or 36.5. Now we are getting the baby to 33.5. Now this ABG does really give adequate CO2, correct numbers of CO2 or PO2. Usually what studies says it, they have pH stat method, what they told that usually given PO2 values and PCO2, if you subtract 5 and 2 from the given ABG, that is the correct values of the PCO2 and PO2. For example, if the PCO2 in your ABG machine is 40, that means 35 is the corrected PCO2 and PO2, and PCO2 decreases by 2. So if it is 40 PCO2, 38 will be the PCO2. If your FiO2 is 65, 60 would be the correct PCO2. So subtract 5 for PO2 and 2 for PCO2. So that gives correct value for your ABG. So why it is important is, again, if your PCO2 is 30 in your ABG, don't feel that I am safe zone, because it's already 28 or 27. So hypocapnia is again less than 30 is bad to the brain. So keep your own 45 to 50. That would be a safe zone, maybe 45 to 50 would be a safe zone. If your ABG is an advanced machine, it can detect the even temperature change variation also. So that's very important clinical point. So usually, if you put a child on, because most of the child we want to manage on CPAP, okay, non-invasive ventilation. If child is self-breathing, if we want to manage the child on CPAP. So I think they will be hearing me otherwise. So usually, what could be the starting for a CPAP levels? Postgraduates are there. How much you will start for a CPAP? The child is breathing spontaneously. Or HFNC or CPAP, you will start non-invasive ventilation for moderate encephalopathic child. The child is sensorium is good. So usually start with 5 to 6 of PEEP and FiO2 of 25 to 30. Repeat ABG after half an hour, and from there you can titrate on. But if the child is having severe metabolic breathing, metabolic acidosis, his PCO2 levels are washed out, then what you have to do? Child is breathing, but he's having acidotic breathing. PCO2 levels are washing out. So it's better to intubate this child, sedate this child, and maintain CO2 around 40 to 45 in the first 3 days to prevent the ongoing brain damage, because we don't want our brain to get vasoconstrictive because of hypocarbia. So, as I said, and PO2 should be maintained around 60. So use humidified heat and gas. Another clinical point is that the secretions will be getting very thick with this when you use hypothermia. So frequent suctioning is also very important. More frequent suction is saline, and regular positioning. Positioning will come to skincare also, is to move easily. So minimum FiO2, because if you have ventilated the child, maybe the chest PIP by PEEP, you can look at the chest raise, adequate chest raise is there. PEEP, you can look at the X-ray and look at the number of ribs, around 5 to 6 can be starting point. PIP maybe 18 to 20, depending upon chest rise. Second thing is, if there is PPHN, associated meconium aspiration, your ventilation requirements may go up. So underlying which cause is causing your ventilation, that is also important. Sometimes, as Dr. Pratap told, HFO, nitric oxide should also help for meconium aspiration to maintain adequate PO2s. Sometimes there are also PPHN also. So you have to take all this consideration into account. So usually, if lungs are only asphyxiated, not associated with meconium aspiration, minimum chest rise, PO2, PO2 should, FiO2 should be minimum, around 35 to 40, depending upon your ABG values, you have to titrate. Don't start directly with 100 FiO2s. So keep your FiO2 very minimal, nominal thing. And second thing is, as I said, optimal PCO2 loads 40 to 50 should be maintained. So the optimization of respiratory management with the currently available techniques may be important approach to enhance the neuroprotective effect of hypothermia and could be proven to more cost effective when compared to the recently tested adjunctive pharmacological. So this very, very important statement, because maintaining adequate CO2 and PO2 levels are very, very important. That's what I'm studying these slides actually. So if you take a lot of baby, you can't see the baby here because baby is already cooling machine is there, transcutaneous PCO2 monitor, cerebral oxygenation, NIRS is be using, say cardiovascular motor, ampullary training. So if you want to actually treat, you have to get all this into your board. But practically is not possible in India. So we can clinically, you have to sit beside the child and you have to look at the, as madam has said, perfusion status can't be assessed with your, because you are cooling the baby. Functional echocardiography that we'll discuss is very important tool in assessing the cardiac status. So assessment of circulation status, as Dr. Pratap has said, it's very important to look for the blood pressure, heart rate and perfusion states. So what happens to your heart rate while cooling? So for every 1 degree centigrade decrease in your temperature, your heart rate will decrease by 15. So 70 to 80 is acceptable until your urine output is good, perfusion is good, like urine output, because you can't assess the capillary refill time in cooling babies. So urine output, your lactate levels are good, your ABGs are showing good PCO2, PO2s, everything others are good, parameters are good. You can monitor up to 70 to 80. If it's coming less than 70 or 65, then you may have to get full ECG and look at the electrolytes, what are the potassium, calcium, magnesium, all this to be corrected for this bradycardia. So continuous monitoring of arterial pressure through arterial line is very important for managing sick child. Without NIBP is not at all reliable while cooling. So IBP is very important, either through peripheral arterial line or umbilical lines should be inserted before you start cooling. So to maintain above 35 to 50. Why? You got mean arterial pressure. To maintain cerebral perfusion pressure, again your mean blood pressure is important. If your child is hypotensive, your cerebral perfusion pressure can't be maintained, and whatever you do your ventilation circulatory status without knowing the BP, so then why the child is having hypotension? As Dr. Pratap said, don't keep on giving fluid pulses. It could be, you check at the IVC if you have functional echo. If it is narrowed, if it's collapsing, then you can try fluid bolus. Second is myocardial injury, because I told HIE affects each and every organ. Heart is also affected. You will get asphyxiated heart injury. So myocardial injury may be there. Then LV dysfunction can be there. You have to add inotropes. So depending upon what is the cause of hypotension, is it because of fluid depletion or is it because of myocardial injury? You have to treat that one. So depending upon inotropes, depending upon if LV dysfunction, you can start with the dopamine or dobutamine, or some centers starts adrenaline. So that's how you have to assess. Then coming to the fluid and electrolyte balance. So one of the most important, if you want to win the game, if you want to win the battle, fluid and electrolytes are very, very important. Measuring the urine output is very, very important. It's our low-tech CVP, what I can tell. To win the battle, we should have adequate urine output. So measure continuous urine output. If child is not passing urine, you can catheterize the baby for initial few days. But if child is passing, you can wait the diaper is also. So urine output, how does it tell us? So as I said, management of PPHN as I said. So PPHN should be managed as per the guidelines of PPHN, depending upon your OI, whether you have to start your HFO or nitric oxide, you can go with. I'm not going to deeper that one. You usually do trophic feeds or NPO usually. Yeah. Yeah, that's what. Usually minimal enteric feeds are NPO, whichever, because perfusion metabolism will be low, gut supply will be sometimes low, so they don't feed the babies usually. So IV fluids again, is it 40, 50, 60? Because we all know HIV will cause SIDH, syndrome of inappropriate ADH secretion, will lead to water retention. So dilution hyponatremia can be there. So sodium will guide you. Electrolyte sodium will guide you to how much fluid you have to start, whether 50 ml per kg or 60 ml per kg you can start. But check electrolytes 4 to 6 hourly, and then you can titrate your fluid depending upon your heart rate, your electrolytes, your urine output. Then you have to titrate. But usually for first 2 to 3 days, 50 to 60 ml per kg. If your sugar levels are normal, if sugars are low, you can increase the percentage of your GIR. So usually 50 to 60 ml per kg 24 hours and adjust based on stick, because increasing fluid sometimes will cause increased cerebral edema, also increase. If you have dilutional hyponatremia, cerebral edema is also increased. So all the procedures what we are doing to maintain strict neuroprotective measures, these are ventilation strategies or circulation strategies or fluid and electrolyte strategies. All these strategies we follow, then only your therapeutic hypothermia effectiveness will increase actually. So maintain and glucose and electrolytes within the normal limits. As I said, hyperglycemia and hypoglycemia both are bad to the brain. So I think this point has been clearly told by Dr. Pratap, that no bicarbonate for acidosis, because it's more of what is the root cause of acidosis that we have to see, not that simply giving bicarbolus will cause intracellular acidosis and your hypoxia will still increase. So don't give soda bicarbonate frequently, it's not required. And most important is avoid using nephrotoxic drugs, because sometimes what happens is child will be completely anuric. Maybe we have seen few babies who, because of ischemic renal damage, they accounted into AKI, acute kidney injury, which lasts for 2 weeks. They have to get peritoneal dialysis also if the child is requiring anuria. So depending upon severity to whether to put PD or not, you have to assess. You are depending upon urea, creatinine, urine output. So neurology, it's very important that infants on therapeutic hypothermia, frequent neurological assessment like pupils, level of consciousness and raised ICT should be maintained. Usually these babies will be shivering. Cold stress is quite painful. Another practical point is you may start low-dose fentanyl for these babies because it's quite painful, and if a child moves and his temperature goes up, the hypothermia is also not effective. So keep the child sedated. Low-dose fentanyl is quite effective. We have seen a lot of babies will be happily sleeping on low-dose fentanyl. And so signs of inadequate sedation such as tachycardia, shivering should be treated. Otherwise, your therapeutic hypothermia is not effective. Watch for over-sedation, especially when you're giving seizure management, especially for phenobarbital, where the metabolic, usually it is 3 to 5 days for half-life of Gardneril. It might increase because of decreased liver metabolism. So sometimes your neurological examination will be obscured, like Thompson score will be obscured if you have over-sedated. So it's minimal sedation is required, and of course monitor the pain scale. Now it's very important you look at how is the cerebral edema, you look at the cranial ulcer and resistive index, RI, what we see usually. It should be between 0.5 to 0.8, less than 0.5 and more than 0.8, both are bad for the brain. So adequate blood flow, adequate resistive index should be there. So it's very important prognostic marker. So if you have AEG, you can start AEG monitoring, and seizures to be very particularly treated very well. Otherwise, your brain damage will be ongoing. Sometimes child may be non-convulsive status can be there in the brain. So EEG will pick up that one. You have to treat each and every seizure there. So you can use 12-lead EEG also. So adequate seizure management is required. And of course, MRI has to be done as told by Dr. Pratap, 4 to 7 days. Because with your ADA and diffusion weighted images, especially, minor abnormalities in MRI, especially basal ganglia lesions, will be picked up after 4 to 7 days. And after 7 days, if you do the MRI, there will be pseudo-normalization. So to give the prognosis, you have to do the MRI within 4 to 7 days. Of course, all the bloods is very important. I told about ABG, importance of ABG, how to calculate the ABG, and how frequently we have to do. So depending upon requirement once, usually we can start fourth hour, 8th hour, 4th hour, 8th hour, 12th hour, 24 hours and 72 hours. This is a rough guide, but depending upon necessity, we have to repeat the blood test, especially ABG, electrolytes, renal function test, liver function test, because coagulation profile, PT, APTT and fibrinogen level, sometimes they require FFP also, because all this will be deranged while you are doing Bathasfixate will be deranged and hypothermia will also be deranged. And of course, blood sugar. So all these blood parameters has to be taken care while you're managing child on therapeutic hypothermia. Now, skin care, integrity of skin care, every 6 hours you have to position the child, because what happens is, I will tell you, hypothermia can cause severe immune dysfunction. So strict aseptic precautions as you take in a level 3 NICU, proper hand washing, proper touching the child, if required, send the cultures and start on antibiotics. Per se, antibiotics, depending upon unit protocol, you can start the antibiotics. So coming to the last few slides, side effects of hypothermia. Local, we have cold injury syndrome, scleroderma, skin erythema, acrocyanosis, and most important is subcutaneous fat necrosis. Sometimes the practical tip is here is, sometimes subcutaneous fat necrosis will cause hypercalcemia. So your this may take for 2 to 3 months also resolve. So calcium levels sometimes may be high. So 1 or 2 weeks later, child may present vomiting or not. So if you see the calcium, it might be high. So hypercalcemia should be treated. There's a practical tip here. So systemic complications, yeah, overcooling in low resource setting can cause further bleeds, IC bleeds or GI bleeds, pulmonary hemorrhage, renal failure, increased chance of infection, acid-base balance. If you don't follow strictly follow the protocols, what we have mentioned now, what we have discussed now, all may lead to complications. So I think this put a video. I think video will not play, right? Sure, sir. Whatever I told, I have just put a video here to understand. It's not playing. Okay. So that's what. Thank you very much. So any further doubts?
Thanks, Dr. Ram. You gave a wonderful outline of management of babies with HIE, not just therapeutic hypothermia, but you also concentrated on each and every system. And I hope it's been very clear. Is Dr. Shishir here? So there's just one small change in here. Dr. Shishir has to go somewhere else. So he's going to talk next about the recent advances in the management of HIE. And over to Dr. Shishir.
Thank you so much. Can this be removed? Can this be removed? No, the first slide. Yeah, hi, I am Dr. Shishir. I am a consultant neonatologist, and I'll be talking about recent advances in management of hypoxic ischemic encephalopathy. Next slide. Thank you. So I'll talk about the terminology. Perinatal and neonatal depression pertains to immediate postnatal period, which includes depression, mental status, muscle hypotonia, and disturbances in spontaneous respiration and cardiovascular function. Neonatal encephalopathy. If above condition persists after the first hour of life, then neonatal encephalopathy is better a terminology. Hypoxic ischemic encephalopathy. It is a term that describes clinical evidence of encephalopathy as defined earlier, with objective data to support the hypoxic ischemic mechanism as an underlying cause of encephalopathy. Etiologies of hypoxic ischemic encephalopathy may be multiple and may include the following. These are the major etiological factors which conclude to the hypoxic ischemic encephalopathy. Maternal factors, hypotension, hypotension, acute or chronic infection, including chorioamnitis, hypoxia from pulmonary and cardiac disorders, diabetes, maternal vascular disease, and in utero exposure to cocaine. Placental factors, abnormal placentation, abruption, infarction, fibrosis, or hydrops, uterine rupture, umbilical cord accidents, abnormalities of umbilical vessels, fetal factors, anemia, that is from the fetal maternal hemorrhage, infection, cardiomyopathy, hydrops, and severe circulatory or cardiac insufficiency. Now I'll talk about pathophysiology not in detail because some of my colleagues have already spoken about it. This is a rough picture of the pathophysiology of hypoxic ischemic encephalopathy, and you can go through it. I will not go into the complete detail of this pathophysiology of hypoxic ischemic encephalopathy. Current standards of care. Baby managed at birth according to neonatal resuscitation program. The infant is evaluated for hypothermia, which should ideally commence within 6 hours of birth for infants with moderate to severe HIE. Improved motor outcomes have been noted with earlier cooling within 3 hours after birth. Yeah. Supportive management of seizures, fluid balance, and hematological and cardiovascular abnormalities is essential in ensuring optimal outcomes. Presence of multidisciplinary team, including pediatric neurologist, cardiologist, and other super specialties, as well as institutional capabilities of long-term EEG, MRI, and physical and occupational therapies are requisite for establishment of cooling protocol at a tertiary institutes. So as soon as we have a baby who requires cooling and we have a serious baby like that, we should try to refer the baby to the tertiary center rather than trying to do it at the primary or secondary center. Now I'm going to talk about the evaluation of HIE and emerging modalities. Emerging biomarkers. You have skipped a couple of slides. S1, let it be. S10B, 100B, is a calcium binding protein released by brain glial cells in response to injury. Elevated levels of
Recording in progress.
Elevated levels of S100B have been evaluated in cord blood, urine, CSF, as well as amniotic fluid for newborns with HIE or encephalopathy. Neutron-specific enolase, NSE, is a glycoside isoenzyme that is released after neonatal death. Click et al. Identify NSE cutoff values that could help differentiate and moderate and severe encephalopathy. Glial fibrillary acidic protein GFAP is released with damage to astrological cells, and levels in blood and CSF have been seen to correlate with severity of HIE MRI changes. Interleukin 6 and interleukin 1/6 in cord blood were found to be significantly associated with echocardiography and clinical HIE severity in a study of full-term infants. Imaging. Magnetic resonance spectrography. It is significantly important for our understanding of the changes of brain, changes in brain metabolism, and evaluation of brain injury after a hypoxic ischemic insult. It could help define a severity of injury if done during the treatment window within 6 hours by estimating phosphocreatinine and cerebral initiate and inorganic phosphate. Higher PCR has been associated with a favorable outcome with high lactate, and PI may indicate a poor outcome. MRS after 6 hours continues to provide useful clues to help the clinical procrastinate HIE insult. Low cerebral PCR or PI, a high cerebral lactate, and decreased nucleoside triphosphate levels are associated with poor outcomes. Persisting brain lactic acidosis on MRS is seen in infants with poor neurodevelopmental outcomes throughout the first year after birth. Emerging therapies. Promising emerging therapies and management of HIE mechanisms are, there are some clinical trials and there are some preclinical trials. The mechanism is endogenous and exogenous. In endogenous, erythropoietin, lipoprotein, stem cells, and melatonin. These can be tried. And the preclinical studies for remote ischemic, I can't read it, post-conditioning and endocannabinoids. And exogenous is monoglycosides, xenon, allopurinol, tropicate, magnesium sulfate. And newer trials are agron and azithromycin. This is again about the pathophysiology, which my another colleague will be talking later on today. So I will not go into the detail of the pathophysiology of this again. Potential neuroprotective therapies in the management of hypoxic ischemic encephalopathy. Hypothermia is currently the standard of care in the management of moderate to severe HIE in infants. Erythropoietin production by the kidneys increase RBC production in the bone marrow, thereby increasing O2 carrying capacity. EPO favors neurogenesis, is an antioxidant, AO, anti-inflammatory, and decreases apoptosis and exotosis cell injury. ZooCL study shows promising results in improved neurological outcomes. Stem cells. A meta-analysis of MSCs, mesenchymal stem cells, demonstrate a significant positive effect on neurobehavioral outcomes following HIE injury. Myostasis, SA. This study has shown that cord blood stem cell therapy has could have productive effects mainly on inflammation, apoptosis, oxidative stress, and may enhance regeneration. Remote ischemic post-conditioning exogenous. The concept of remote ischemic conditioning involves delivery of sublethal small ischemic insults remote from area of injury that activate endogenous repair pathways, which potentially help in reducing the extent of original ischemic injury. Endocannabinoids, exogenous. Endocannabinoid system has been recognized as an important neuroregulatory mechanism that could help in protection from brain injury. Aviation of this system has been shown to decrease glutamate, exogenicity, and activation of microglia and cell death pathways. Gangliosides are sphingolipids that serve an important function in maintaining the cell membrane integrity. In a rat model of neonatal hypoxic ischemic injury, reduced ganglioside phospholipids and cholesterol concerns in the hippocampus were noted. Monogangliosides therapy has been shown to protect against apotropic injury. Xenon. Acute hypoxic ischemic insult leads to NDMA receptor activation through through neuronal depolarization. Xenon inhibits NMDA signaling and thus play a major role in reducing the acute injury of the cell injury. Allopurinol. Oxidant injury by free radicals and suboxidase forms through activation of xanthine oxidase pathways contribute to the damage caused by hypoxic ischemic insult. Allopurinol is a xanthine oxidase inhibitor that is being investigated as a potential agent for use in treatment of HIE. Magnesium sulfate. We have been using magnesium sulfate from quite a long time, and it has been effective pretty much. Magnesium sulfate is an NDMA receptor antagonist believed to reduce endosonic damage effect, hypoxic ischemic insult. We have been using magnesium sulfate in the primary care center as well. It is now being widely used antenatally for neuroproduction in preterm deliveries. Initial interest in use of this medication was generated due to low magnesium levels being noted in an infant with HIE. Tropicamate. Tropicamate blocks the voltage-dependent sodium and calcium channels and also inhibits the excitatory glutamate pathway while enhancing the inhibitory effects of gamma-aminobutyric acid. All of these effects would work favorably in the pathophysiology of HIE. Azithromycin. This is something new and which we can start as soon as the baby is there. It has got no side effects. Preclinical studies in models of ischemic stroke have revealed that azithromycin has a neuroprotective effect. Recent abstracts have investigated the possibility of using azithromycin in neonatal HIE alone is an adjunct to the hypothermia. So we can use azithromycin whenever required. References, these are the references. Thank you. Thank you so much.
Thank you very much, sir, for the detailed description of the recent advances in the management. See, a lot of these are used as the adjuncts. Okay, so therapeutic hypothermia is the only proven one. Now, erythropoietin is showing much promise in the recent times, and a lot of units have started using erythropoietin also, right? And the rest of it are actually still in the experimental phase, right? So this is for us to understand therapeutic hypothermia or HIE management is so complex that it cannot just be one way of managing it. Thank you so much, sir, for enlightening us. Thank you. And next one, I think we will get a little peppy talk from Dr. Deepa Mohan Sharma. We have highlighted in the Helix trial, Mangal Bharti did it this morning, where he said none of the babies who were included in the trial were retrieved. This is very important. So no baby in that Helix trial was retrieved. So we are one of the, I don't know about any other unit who's doing, do you do active cooling during transport? So we're the only unit who's doing active cooling during the transport. And Dr. Deepa Sharma, is one of the stalwarts in establishing that. And I would like her to share, the experience of neonatal transport and therapeutic hypothermia. Thank you.
Thank you, Dr. Pratap, for the kind introduction.
So I totally understand we didn't even take a coffee break. I'm so sorry about that. I think we are running quite late in here. We'll do two or three more sessions and then go directly for the lunch. And after that, I think it's going to be more interesting in the afternoon.
Yeah, I think even for my topic, I'll be doing the neonatal, cooling during transport. The other part, which is nursing skills during cooling, we'll have it during the afternoon session.
Recording in progress.
Okay, so till now we've all heard that cooling needs to be started as early as possible, and especially the TOBY trial has told that if we start cooling within 4 hours, it's more beneficial. So now, why are we focusing on transport during cooling? Cooling during transport. And why is it that we cannot start cooling later? All of these points I would be speaking now. Can you please share the slides? right, so the recent data in 2017 also says that we can think of cooling after 6 hours, that is within 6 to 24 hours period. And that has shown that around 77% of babies which were enrolled in the trial, and there was benefit, as in there was delayed, there was benefit in motor outcomes, and also that death and disability was reduced in 76%. But more data is required, and that's why we should not think of late hypothermia at this point. Now, why do we cool during transport is because of this 6-hour window. We know that more than 50% of these babies who are brought in for cooling are outborn, or these are born in babies where there is no cooling facility available. So we have lots of referral calls wherein the pediatricians from other centers request us to retrieve babies who require cooling. So we need to maintain this, that we start cooling within 6 hours. So we have to give them advice that either you start passive cooling at your center till the team reaches, or do active cooling with other measures like ice packs or gel packs, and then we can continue the cooling during transport. So as the studies have suggested, earlier we start cooling, better is the outcome. So we suggest that don't wait till the team reaches your center. Start passive cooling in your center before the team even reaches. Now, passive cooling, like Dr. Ramprasad already mentioned, we are switching off the warmer. So as soon as a baby is born in a center which does not have cooling, we are saying that you switch off the warmer. So switching off doesn't mean completely zero. You need to turn the warmer to manual mode and make it at 0% heater output. And why is that important is because you still need to monitor continuously the baby's temperature. So if possible, if you have a cardiac monitor which you can attach a rectal probe, so you can have even a rectal temperature monitoring as well as your skin probe to be attached to the warmer. So you have a continuous surface and core monitoring going on. So with the passive cooling, you're not using anything, any device to cool the baby. You're just switching off the warmer, simple. Okay? No clothing or blankets, because you want that the baby should be cool. So what we need to do is keep monitoring continuously. This would need monitoring every 15 minutes. So initially, what you need to do is get the clothes out, switch the warmer, make it to manual mode, 0 heater output, then recheck the temperature in 15 minutes. If the temperature is going beyond 34, you may have to then start active cooling, as in using gel packs or ice packs, or in some centers we may use a fan also. Okay, now think of temperature is quite varied in our country. Some places you may have your environmental temperature just around 40-45 degrees. Some places it may be freezing cold in winters. So it's very difficult to just maintain cooling using passive cooling methods. So this is a flow chart which a similar one Dr. Ramprasad already shared. So if the temperature, baby is getting overcooled, you can use a hat or you can use a blanket. If the baby is not reaching 33 to 34, you can use a fan. Okay. Please make sure that you do not use these methods for cooling the babies for the entire period of 72 hours. We just need to use it till the help arrives, till the transport team is reaching your unit. So with the passive cooling, since you're not using any of the cooling devices, here the temperature would drop very slowly. Say if your ambient temperature is around 40-42 degrees, your temperature, even if you switch off the warmer and your environmental temperature is 40 degrees, it's not going to help you much. So you may need some device like a fan, or put on the air conditioner so that the temperature would drop. So when to reach the target temperature of 33 to 34, it takes a lot of time. Also, to maintain the temperature, it needs a lot of help. So you may have to welcome, sir.
all the work you are doing. Dr. Pratap Chandra, is Mangal Bharati online? Is there Dr. Deepa and all the faculty? I know that it's one of the current controversial what you call as interventions, but I think we should come out of these controversies. Dr. Pratap Chandra will guide you there, and we carry on with our work. That's the most important thing I'm telling you. So please go ahead, learn and disseminate the knowledge and practice. I thank you all and thank all the faculty for taking their time off.
Okay, so I'll just continue. So we were talking about passive cooling during transport, and let's just say this is a stopgap arrangement. We're not going to use this for 72 hours of cooling. So it needs a lot of staff manipulation to reach the target temperature and to maintain that till the help arrives. Also, we know that if we record and keep a record of those 2 hours or 4 hours of, till the help is reaching, suppose the place where we need to go is 200 kilometers from Bangalore or so, and if they document and keep it, we'll know that there is a lot of variability in the temperature that is there. So not always the baby would be in the required temperature of 33 to 34. Now, active cooling, like I mentioned, this can be done using gel packs, ice packs, fans, or using the air conditioner. Similarly, here we are not going to use this. This is also an interim thing till you are going to get a servo controlled or a phase changing material, okay, to help with the cooling. So only till the transport team arrives, do not use for the whole duration. Do not let the ice packs or gel packs come in direct contact. So we need to make sure that you put a thin bed sheet and then put the baby on top of these gel packs. Now coming to servo control, these devices have really made our life easy to cool the baby, and that is because you just set the temperature, then how much ever the baby requires to be cooled, or suppose if it's really getting warm, so it will bring the temperature down further, or suppose if it is getting overcooled, it will provide a little bit of warmth. So this machine is going to help us, and most of the servo control machines like the Ticotherm and the Criticool both also offer rewarming. Okay, so it's important to ensure that the rectal probe is always in and secured well, otherwise we may overcool these babies. The same device can be used for the whole duration, that is from the transport, continue cooling in the NICU, and then rewarm the babies. So with the servo control cooling, there's less variability of temperature, and we know that to start cooling, the induction phase should be shorter. We should use, within half an hour of starting the cooling, you should reach the desired temperature. So with the servo control, all the machines which we are currently using, you reach the target temperature within half an hour. And obviously, because the machine is doing all the help to maintain the temperature, the staff in the ambulance, when we are going to retrieve, that is your doctor and nurse, can look at other things that the baby requires. So they can help with the respiration, look at how the baby's perfusion is, which is not going to be good, but sometimes monitor the blood pressure, load up inotropes or anti-seizure medications. So all of that can be done if you're not just focusing on the cooling. So these are the two devices. This is specific for cooling during transport. And this is because these are lightweight and portable devices. That is the Tecotherm Neo and Criticool Mini. Both have been used for transport. The only difference between Criticool Mini and Tecotherm Neo is that Tecotherm initially said that they wanted to use alcohol, sterile alcohol to as a coolant liquid to be inserted into the machine, whereas Criticool Mini we use sterile water. But with the new changes, the Tecotherm company also says you can use sterile water as well. So there is also a Criticool machine which I think is here. So this is if you had started cooling 4 or 5 years earlier, this was the machine which is about 70 kgs in weight, and there the issue is that it consumes a lot of space. Okay, it consumes a lot of space, and also that it is not easy to carry around when you're going for transport. So now what are the challenges to start cooling? So I would say before we talk about the equipment and issues and challenges during transport, I would say the first challenge is, do we cool this baby or no? Maybe that by the time you reach the transport center, I mean the referral center, your baby may have started kicking, moving around, crying, doesn't need the tube. So sometimes you may have to reassess within a period of 1 hour or 2 hours when you have seen where the neurological status of the child would have even improved by the time you have reached, and now no longer the baby fits into the cooling criteria. So there are a lot of dilemmas whether to cool or not to cool. And when your team reaches the referral center, we always say do a thorough neurological assessment, speak to your consultant, and make sure that you take a combined decision whether we need to cool. So sometimes you've gone there to bring the baby for cooling, but we may have to refuse cooling, but get the baby for other ICU related admissions. So now challenges during transport, specifically to the equipment and things that are in the ambulance. So now portable. So like I said, the weight of the machine can be an issue. Secondly, how big is the machine? Does it fit into your ambulance? And also the cost. Suppose you already have a machine like say this one or any other machine which you're using during your ICU, you don't for one and you don't have many transfers. So in that case, would it be feasible for you to buy a machine which is actually again going to add, and you have to again pay money for that, and how much would it help you? How many transfers do you get in a month? So also none of the machines which are there currently have any battery backup. So they need continuous power backup, which we know the state of our ambulances in the country. So only ambulances which are with the private hospitals have continuous power supply. Also the space in the ambulance. So we know that these machines would use some space. Sometimes you have so many equipments there, so you may not have enough space to put it. So all of these things you need to keep in mind before you start cooling receive a baby or say yes to get a baby for cooling. Also the weight of the equipment, like I mentioned, it may be an important factor when you're airlifting the babies. So this we've just recently started, so that's why we're just focusing on this point. So also ensure that you safely secure these equipment. So there can be, we've seen road accidents, we've had some issues wherein the machine can just fall off. So make sure that these things don't happen if you're starting cooling. So this is just to show how we, I've not put the picture when the portholes or the side port is like complete there. So I've just put it down so just everyone can have a look. So this is how the baby is kept inside the transport incubator, and there is a cooling jacket around the baby, and this is how we get the baby in the road ambulance. So now, like I mentioned, the first important thing is to decide whether you need to cool or not to cool. So what we have to do is have toolkits, have flow charts, make sure that you meet the cooling criteria completely, and then only start cooling from the referral center. Also documentation right from the beginning, right from birth. or even data available before the delivery is very important. So you can have charts like this, which are, I'm sorry, it's not very clear, but this side you can see the hours from birth, and this is the temperature. So every half an hour you can document and see that how much time it took you to reach the target temperature and whether there was any fluctuations during the transfer. So this can be even a part of your QI project or your audits when you're doing the transport audits. So these resources we have seen in the bebop.nhs.uk. Please visit this site. You'll have lots of important flow charts and documentation right from, you know, at admission to cooling cooling on transport, continued cooling till the end. So it can be a full file that you can prepare with this. So yeah, what do we advise our referral centers? We tell them to take printouts, educate them that, you know, they need to inform us as early as possible and not delay the time, because it's time critical. We need to start cooling within 6 hours of birth. And CMEs can be helpful for that. And establish a network around your hospital where you can, you know, get retrieval calls, have these toolkits there, whether they can have a flow chart and easily decide whether they need to refer. Sometimes you need to just wait for an hour, re-examine, and then, you know, the whole neurological status may change. Now coming to training for your staff, you need to have mock drills so that this whole process can be done smoothly. You need to have checklists so you don't forget anything. You need to have your transport checklist, your transport kit. You need to make sure, especially for cooling, what are the things that you can forget while you're going. You need to also have, get them to do important troubleshooting kind of this thing, wherein, you know, you give them what will you do if, say, baby's BP comes down. What would you do if the baby is desaturating on the way? So similar exercises you can do for the training of staff. And main thing is to cool or not to cool. This is always a dilemma because you need to depend on a third party to give us the information and then go for cooling. In terms of research, as the NNF statement has come in, we need to definitely have a national registry of all the babies who require cooling and who will be undergoing cooling. We need to have audits. Like I mentioned, we should have audits of, say, when by the time you reach the hospital, what was the temperature? Did these babies have hyperthermia? Did they have hypothermia, as in below 33 or 32 degrees? And when did you start? And after starting, how long did it take for you to reach the target temperatures? So you can have many audits in the same way. So also QI projects to help your hospital or your training team, transport team, to improvise. Now, so I would just be mentioning on a small data which we collected, and this is specific for active cooling during transport. We presented this in the South Neocon in August. So this was by Motherhood Hospital, Indiranagar, and the study period was between December 2018 to June 2021, and 50 babies were included. So inclusion criteria was, we included all babies who satisfied the TOBY cooling criteria. So totally 86 babies were cooled in our unit. So in that study period, in the inborn, 19 babies were cooled. So these were excluded because we are only talking of active cooling during transport. So out of the total 67 who were outborn and then transported to the unit, we again excluded 17 babies because they were just from local nursing homes, so we did not start cooling them, and it was less than half an hour that the baby is required to reach the center. So total babies included were around 50. So long distance transfer in these were around 62%, that is more than 100 kilometers, and short distances less than 100, 38% of the babies. Now passive cooling at the referral centers, almost 74% of our referral centers had started passive cooling by the time we reached. So as soon as we get a referral call, we inform the consultant or the doctor who speaks to us to start passive cooling and guide them how to do it till our team reaches. So the respiratory support during transport, majority of them were ventilated. However, there were some on LFNC and in room air as well. So 92% of the babies were stable throughout transfer. And there were issues like blood pressure was low. We had to start inotropes during the transfer. We had to give a bolus sometimes. But all the babies maintained the temperature between 33 to 34. Now, after finishing this study, we realized that we should also start seeing that how long it took us to reach the target temperature. We just saw whether they maintained the temperature range, but we need to see now, from now onwards, that how many babies took how long to reach that range. Okay, so 16% of the babies had seizures, which were controlled by one anticonvulsant. This is specifically only during the transport time or the transport period that I'm mentioning. So adverse events during transfer, there were 6 babies out of 50 who had desaturation, and the standard measures like suctioning, repositioning, and sometimes just changing of the probe helped us. Rectal probe failure, 2 babies, the rectal probe did not work for some reason, and we had to just manage with the surface probe for the transfer. And one time we had an extra probe, so we used that. One case there was accidental intubation where we had to re-intubate the baby. So coming to the final slide. So transport during cooling is required so that more babies can be included and helped. So we need to make sure that you provide good care for babies who deserve it. So servo-controlled therapeutic hypothermia during transport is what needs to be done. We do not even advise gel packs or ice packs. It is only till the help reaches the center. And temperature maintenance is unaffected even in long distance retrievals. Passive cooling before initiation of transport enables many babies to be included in the servo-controlled hypothermia. Thank you. So my next part, the nursing skills, I would be talking in the afternoon.
Thank you very much, Dr. Deepa, for giving us an insight of active cooling during the transport. Are there any questions?
Yeah, so I think about 42 babies were there.
42. Out of 50, 42 babies were ventilated.
42%, I think. Sorry, 42%. 12 were on HFNC, 14 on, I think, room air. 42%.
Very well done. Did you use any fentanyl or anything?
Any sedative during transport?
During the transfer, unless the baby is really active, trying to pull the tube out or in those situations. If anyways, the babies, most of them are in moderate to severe encephalopathy, so they would be quite dull, hypotonic. So we do not really recommend sedation during transfer. That would even impair our assessment at admission. Yeah, so what happens is that once we are cooling the babies, and so we're maintaining only gap of like 5 to 10 minutes till you bring the baby from the ambulance into the unit. So most of them are between 30 to 30.
So the emphasis is this was servo controlled. Hi. Who's this?
The things is not audible to the virtual people who are attending the conference. So kindly unmute. We are able to see you, but we are not able to hear anything.
Unmute Manapananda. Did you not hear any of the talk? Did you not hear any of the talk? Can you hear us now? Virtual people? Screen sharing pause.
Yes, now the voice is coming.
And the screen share is okay? Resume share. Can you hear us now?
I can hear you now. Thank you so much.
Okay. So basically, yeah, active cooling during the transport, the advantage is you're actively cooling and you've got a servo controlled machine for that. So therefore, as soon as you reach the unit, you put the jacket on, it takes about 15-20 minutes for it to reach the temperature. And after that, it is going to be maintained. So there's no question of a variability of the temperature, right? Any other questions?
Please put everybody here, whoever there, put your double vaccination right now in your groups.
Yeah, kindly put the vaccination certificate in the group. I've already messaged in that group.
Right now, sir, right now. Yes, because they might come and check our group right now. They might come. They have already come in.
Okay.
Please.
Great. Okay, thank you very much. And I think Dr. Ravi Swami's talk is going to be post-lunch. So in the meantime, can we get Dr. Deepak Vasudev? He's a consultant neonatologist pediatrician at Cradle, Apollo Cradle Hospital. And he's going to talk us through amplitude EEG in HIE and its additional clinical applications. We also have amplitude EEG in the workshop. So yeah, you can use the time. Thank you.
Thank you, Pratap. May I know how many of you are using amplitude EEG? Sidhu, yes, yeah. Susan, Motherhood are using. You're from which place, Amma? Delhi you are using, okay. And any delegates, anywhere, anybody has seen amplitude EEG? Virtual, anybody has seen, anybody using amplitude EEG?
Yes, yes, sir. We are just started using in KGMU.
Okay, ma. Thank you. I think we are being cooled. If you're feeling, your legs are stiff or anything, you can get up and then do some exercise. And it's a long day. Hopefully, we'll get some teas or refreshments. Organizing team, no. Pointer is there, Amma. Not that one. Okay. I think I gave you the stick, right? Yeah. Pen drive open madappa. Open here now. The AEG one. Just go back. No, the last one you went down, AEG. Come down, HP is there. Just come down here. Yeah, you can see the screen, right? Yeah. So this is briefly about amplitude integrated EEG. So the aim of this talk, 20-minute talk, would be like how it works. Okay, how we can use it in identification for cooling and seizure detection, and also for prognosis. Yeah, and also if time permits, we can think about other scenarios where this amplitude integrated EEG is used. Next slide, please. Next slide. Right. So this has been extrapolated from adults. Yeah, this was first used in adults by Pryor and Maynard in 60s, and this came into the NICU 2 decades later. The reason for this interest in cerebral function monitor is, as you know, the EEG, it needs a lot of technical expertise. You need neurologists, neurophysiologists who can assess, and also it needs a lot of equipment. And out of hours, you don't know the, you want to know the status, mental status and brain function. So this has been extrapolated, as I said. Just go back now to the slide. Yeah. So the reason is you can directly know what you're doing. So the cerebral function monitor, what you're doing is you get to know the EEG, or the brain function, amplitude integrated EEG in front of you. And you can also note whether there is seizure. And you can take decisions from minute to minute basis. Yeah. Can you put on the screen up? So all of you know the EEG, right? Yeah, the EEG, how it works. The EEG means that you are measuring the brain activity, right? So between two electrodes. EEG, standard EEG in newborns, you need around 10 to 20 channels, right? So what amplitude integrated EEG it does is it takes out the amplitude. Yeah. So when you have the waves, you have waves which have a high amplitude, and certain waves you have small amplitudes, right? So the high amplitude is depicted as the upper border of cerebral function monitor, as in amplitude integrated EEG. So in amplitude integrated EEG, you are seeing the high amplitude as the upper border, and the waves with low amplitude, it is depicting as the lower border. Okay. Next slide. Just go back. Yeah, brain activity. Next one. Next. Right. So standard EEG, as you see, you have 10 to 20 channels, and this is like amplitude integrated EEG. Here, what you have is a pattern. And in standard machines, you also get a EEG and also amplitude integrated EEG. And the waves which have a high amplitude is depicted as the upper border here. And the lower amplitude, you get as the lower border. Okay, standard EEG, as you see, you have around, as I said, around 20 channels. And then generally 4-channel EEG, amplitude AEG, what we use 4 channels, C3, P3, C4, and P4. Next slide, please. So when it came, we were using two scalp electrodes, but right now the standard is 4 scalp electrodes. And what you do is, next slide. So you have left and right. Yeah, so you have a raw EEG on the top here, and this is a cerebral function monitor pattern, or AEG, what we call. Okay, and so as I told you, the high amplitude is, next slide. No, come back up. Why you are changing it? So you have the upper border by the high amplitude, the lower border is from the low amplitude waves. And when you put a cursor here, so this is compressed. This cerebral function monitor, what you are seeing here, the AEG, it is compressed. So one box is roughly is equal to 1 centimeter. It provides you 10 minutes of brain activity. So if you put a cursor here, okay, so you can also see the EEG pattern, so that you can go back and review also, right? Let's go back. Go back. Yeah, stay there only. Because this is an important slide that you should understand this one. So if you roughly around 6 centimeters of activity would equal around 1 hour of the brain activity. Okay, and if you put then the EEG also you can share. So you get a pattern something like this. So this is the EEG and this is the amplitude EEG. This is the left and this right. And also you can see cross cerebral, yeah, so which we use to assess the pattern. Next slide, please. Any questions in this one? Anything which is not clear, just ask me, because we'll cover this in the practical aspects as well in the afternoon. So whenever you are seeing amplitude integrated EEG, there are three things you need to know. It's very simple. I'll make it simple. One is the bandwidth. Yeah, pattern is the bandwidth. Second one, whether there is a sleep and awake cycle. So whether it's a wavy. Yeah. Third, most important thing is whether the baby is having fits, seizures. So three things only: bandwidth. Okay. Look for sleep wave cycle, and the third one is a seizure. Next slide, please. So how do you classify the AEEG? Yeah, so there are a couple of classifications. So the normal one would be something like continuous normal voltage. So you know the lower margin would be above 5 to 7 and the upper margin will be around 10 to 50. And in preterms less than 36 weeks, the lower margin can be a bit low. That is discontinuous normal voltage. So some people take it as normal in this one. But if you have moderate encephalopathy also, you will see something like discontinuous normal voltage. The severely abnormal traces would be like burst suppression, continuous low voltage, and flat trace. Next cycle, next slide, please. So the pattern classification I told you, as so when you see the pattern here, you know, you can see it's like wavy. Yeah, so you have a band which is not very wide here, and the baby is sleeping here, it becomes wide. So the wavy thing, what I described to you, is like the normal. Yeah. So if you look into the normal, the lower margin, so lower margin, ignore the brief spikes here. The dense margin, lower margin, if you see, it's above 5. Okay, and the upper margin also is probably around 40 or 50 in this here. Yeah. So this is the normal trace. Yeah, this is the normal trace. And when you come down, when you have a moderate encephalopathy or in preterms less than 36 weeks, your band gets wide. Yeah. So your band gets wide and your lower margin is below 5, upper margin is about 10. So 5 and 10 is the most important numbers you need to remember. Okay. So in moderately abnormal, the lower margin is below 5. And when you come to severely abnormal one, the upper margin also comes below 5. Okay. So severely abnormal, your lower margin and upper margin is below 5 microvolts. And this is like burst suppression. Many people get confused this one, but if you just see the moderate abnormal and the burst suppression, here this is not dense, the upper margin. These are the spikes. Yeah. Okay. And the severely abnormal, as I told you, the low voltage is around 2 to 5 microvolts, and flat trace it's less than 2 microvolts. Next slide, please. So how do we identify whether AEG is useful for cooling? Yeah. So sometimes we get a child, as Deepa has discussed earlier, and Pratap also touched upon. Some of these babies are very sick. They have meconium aspiration, you know. So some of them, they are intubated at birth. So you're not sure whether the baby is really needs cooling or not. So in that sense, you know, when the baby is paralyzed or when you have intubated, you can't really assess the neurological status of the baby. So in that case, you know, or you might put this baby on AEG, and then you can get the trace. Also, it's a standard of care in Western countries, wherein whenever you find when a baby has been resuscitated or cord gas is less than 7, okay. So when you do that, you put this baby on the monitor, and you obtain the trace for 30 minutes to 1 hour, and then you look into the trace, okay. So then, you know, some of the trials like CoolCap and TOBI, they use this AEG as inclusion criteria as well. So the only takeaway from this talk, if I want to emphasize, you don't rely on the machine alone. Yeah. If the baby fits the criteria of cooling, yeah, criteria and B, which is most clinical indication, then you should cool the baby. Yeah. AEG will give you some information, but you should not use that as a sole criteria for cooling. Yeah, that's the takeaway. The reason why I tell you is the next slide, please. Yeah. So this is a study from cooled babies who thought the cerebral function, this trace was normal. Yeah. So, but then when the experts analyzed it, you know, out of 17 cooled babies, only 4 of 17 was truly normal. Okay. 3 of 17 had like ECG artifact, and 10 of the 17 babies had shivering. When you know, so when you are cooling the babies do shiver, yeah. So that can produce an artifact which looks like a normal trace. So this is the baby, you know, if you look the trace here, it probably looks okay here. Maybe the lower line is below 5 here. And they have given, this baby was shivering, so they have paralyzed the baby, and as you see, the trace is very low here, yeah? So it's severely abnormal trace. So very important takeaway is AEG, so it should not be used to, you know, identify cooling criteria. So you can use as a supplement. Next slide, please. So can anyone tell what is it? Is it normal, this trace? On your left hand trace. Yeah, it's wide, no? It looks wide, and upper margin is more than 10. Yeah, so this is like moderately abnormal. So this moderate encephalopathy will have like moderately abnormal, and this is the normal one, as you say here, the wavy trace. And what about this one? See, burst suppression, right? Yeah, very good, very good. Yeah, so as I said, no, you assess the dense trace here. Dense trace is here, and this is like lighter. These are just brief spikes. And this is, yeah, upper margin also less than 10. So ignore these brief spikes. Yeah, that is the idea. So if you draw here, so that will be less than 10. So this is severely abnormal or continuous low voltage. Okay, and the last one, flat trace. Yeah. Flat trace, yeah. So next slide, please. So this is interesting, right? So seizures detection, as one of the speakers was mentioning, 50% of these babies have seizures, right? So, and diagnosis of seizures even for a experienced clinician can be difficult at some times. And the one other thing is like 1/3 of seizures can be subclinical. I think Ram Prasad touched upon it, yeah. So, and also there is evidence to say that, you know, these seizures can be subclinical seizures, also can be as bad. So most of us probably would treat subclinical seizures also if it's confirmed on the EEG or AEG. And also overdiagnosis is very common. Overdiagnosis, whenever somebody suspects a seizure, 60% of that may not be a seizure, yeah. So sometimes the babies do lip sparking movements, yeah. So brief jerks, so it may not be a seizure. So you have to identify with either ideally video EEG or this AEG can help you in this identification. And over treatment is not good. Yeah. So if you say, there used to be, I think during my PG days, people used to give phenobarbital as routine. That was long time ago. Yeah, but that's not, that in fact prolongs the stay and also it can be harmful. So prophylactic treatment is thrown out. Only if you have a seizure, then you treat it. Next slide, please. And with AEG, you know, so how do we find out from the AEG? So how does the seizure manifest on a trace? So it forms like abrupt transient sharp rise, mainly in the lower margin, and the upper margin also becomes a bit higher. Yeah, if you have a wave like this, so it shortens and then goes up. Okay. And also always make sure that whenever you suspect seizure, put on the EEG, yeah, raw EEG. There you can see repetitive pattern of sharp or spike waves, okay. And the duration, mainly we say around 30 seconds to 60 seconds of seizure can be detected by AEG. So less than 30 seconds, you can't detect on the AEG. So that's one thing. And the latest machines, they have a seizure algorithm, you know, embedded in it. So it will alert you. So if you buy the technology, and it will tell you that there is a seizure, it will alert you on the machine. So the final, like, you know, takeaway point would be, like always, you should do a conventional EEG, because with AEG, you are assessing the only small areas of the brain, right? So always, so you should analyze, you should get a conventional EEG, even when you have a AEG. Next slide, please. So I think we'll go through this in detail in the afternoon section, but as you see, no, so the trace is, this is like probably moderately abnormal trace. when you come here, the trace has become small, the lower border has gone up, and somebody has, no, if you put a trace here, the corresponding EEG, what you see is a repetitive pattern, right? Repetitive. So this is a seizure. Next slide, please. So a few more examples of seizures here. On this, you can see probably around, trace around 1 to 1.5 hours, 1, 2, 3 here. So wherein the trace has become suddenly smaller here. And if you put a trace here, you can see repetitive pattern. It's not very clear on the screen. And type C, what you see, like sawtooth appearance, right? So this is like status epilepticus. This baby has been fitting, and the red mark here, somebody has given a medication, IV medication, and the trace has become like moderately abnormal, no seizures for some time, and again the baby has started fitting. Okay. And the last part probably we'll discuss more in discussion, like, sometimes, the baby is on high frequency ventilation, so the lower trace becomes upper. It can falsely, you can falsely think this as a seizure, but if you put a cursor here, corresponding EEG, if you see, it's not repetitive. So these are things like when you get more experience, you'll probably need to, you can analyze. But the crux point is, whenever, if you suspect a seizure, put a cursor and then see the corresponding EEG as well. Next slide, please. So in terms of prognosis, right? So you have this machine and then you want to know, you started cooling, whether there is anything you can predict about the long-term outcome, right? So this is like not rocket science. Early normalization predicts better outcome, okay? So if you are cooling, it delays normalization. So whenever you cool the baby and then you have a AEG in front of you, so don't depend too much on that information in first 24 to 36 hours, right? So the next slide, please. So this is comparing AEG and prognosis in non-cooled and cooled babies, right? So infants with good outcome had normalized background pattern by 24 hours in non-cooled. And this delays normalization, I told you, right? By 48 hours, if the baby has a normalized background pattern with sleep wave cycle, then you can be mostly assured that this baby will do well. And if your AEG is very bad at 36 hours, your odds of outcome are around 10 times, like, odds ratio is around 10, they say, yeah? 10 times more likely that baby will have a poor prognosis. Next slide. So this is the conclusion. So it is a standard of care, not in our country, but in Western countries, even, so while referring units also, they put these babies on AEG. And I think this I stressed upon, it should be used to complement conventional EEG. And EEG alone should not be used to exclude neonates from cooling. And around the modern machines, you can say around 70 to 80% of them, it will detect seizures more than 30 seconds. And it can also be used as a prognostic factor in the neurodevelopmental outcome. Next slide, please. So next slide. So just briefly, like one slide only. So who else needs EEG apart from HIE? So whenever you have a clinical suspicion of seizure, meningitis, whenever a baby is paralyzed, sick baby, yeah, especially meconium aspiration initially, okay? And the babies who have abnormal EEG, metabolic ones also, you can put on AEG. I won't talk about preterms and all, but if any questions are there, I can take it up later. And any neonate with encephalopathy, yeah, it's very important. Encephalopathy has many causes, as we know. So that also you can, like metabolic encephalopathy, that also you can put it. Next slide. So in last 1 year, we had 2 cases which we cooled. So one did well. So CFM had moderate encephalopathy. The other one we had to withdraw the care, or the baby, died. Third case, this is the use. So, the baby had metabolic encephalopathy, the 5th one. So the baby was referred with gram-negative sepsis and had a seizure. So we had cerebral function monitoring in our AEG in our unit. So we put it. So the interesting thing is, like, the trace was absolutely like moderate encephalopathy, but had seizure during hypocalcemia that time only. So After that, the baby didn't have seizures. So we didn't treat this baby by continuing the phenobarbital. So only one dose of phenobarbital was given for this baby. So we didn't carry on giving the treatment. Third case was interesting. The 6th day, the baby came with neonatal encephalopathy and resistant seizures. So this helped us. So then baby needed the IV midazolam infusion for 24 hours. Okay. So this was a molybdenum cofactor deficiency. So then we did genetics and all. And the fourth also, it helped us to control seizures. We had to put on 3 seizure medications. So this will help you apart also not in HIE and also in other cases. Next one. I think we have come to the end. Yeah. So any questions? So sorry I had to rush through. Sorry? Yeah. Yeah, it's very easy. So if you just go back. So sleep wave cycle, when the baby is active, so the trace is smaller, yeah, and your lower margin is still above 5. So generally normal babies, we say it's around 10 to 40 microvolts, the range, yeah. And when the baby is sleeping, like the brain activity is suppressed, it becomes wave, like a wave. You have small and then big, small and big, or active. Other thing is when you're doing procedures or anything, when the baby is doing suction. So those are things that can also show like seizures, like a lot of activity can happen. So that it's very important that you mention that on the screen. That we will cover in the afternoon session. So sleep wave cycle basically is like wavy pattern. So different pattern. In moderate encephalopathy, you have the same trace, like wide band, yeah, and usually you have seizures also. So with, like as I told you, the lower border will go up, yeah, and to some extent the upper border also. And then if you put a cursor on that, then you see the EEG, then you get the sharp and the spike waves, the repetitive pattern, you get it.
Thank you so much, Deepak. I think he's going to cover most of it in the afternoon session as well. What is our experience on the amplitude EEG is, why is it important? See, whenever you start cooling, with the severe babies whose baseline is very, very low, will start getting better. So that is how you try to use that as a prognostication as well. And seizures, he discussed in detail about it. And then the second thing is the onset of sleep-wake cycle. A moderately abnormal baby, onset of sleep-wake cycle depicts that the baby is getting better. So yeah, you've got a question?
Decision aid for withdrawal of life support in babies who are like clinically brain dead or with severe encephalopathy. Is there any role of amplitude EEG per se in those babies? Because actually we have seen sometimes, as you told rightly also, that false normal are very well seen. So we see that the baby is actually clinically brain dead. The pupils are dilated, brainstem reflexes are not there, is apneic, but the EEG, the amplitude EEG is still showing. EEG, yeah, so it has no role actually. Amplitude EEG has no role, right? Yeah. Okay.
I'll probably answer this based on the experience when we did the TOBY trial in UK, where yes, it was used as one of the criteria to withdraw the intensive care. In India, it's still illegal to withdraw the intensive care. So don't do that. You can't do that. What you can do, prognosticating, correct.
You can't withdraw, but it will definitely help you in prognostication.
But we can at least de-escalate, right?
Yes, absolutely.
Yeah, absolutely.
If you have done
that, then I can discuss.
Clearly told.
Non-escalation
Withdrawal of care.
Yeah.
Withdrawal of care in a very black and white way is not allowed. We all know that. And the way that you need to do it.
You do it in different ways.
Yes.
So
in UK, definitely yes. So if
yeah.
the baby has no spontaneous breathing, you put on CFM, and if it shows flat race, so we are gone for transport. We don't bring this baby. So we tell them that so the outside palliative care over there only. Yeah, but the two neonatologists need to agree. That is some things, but this can be done in India. But I think to be safer, you get a EEG.
Proper EEG, and then still don't withdraw the intensive care. Secondly, this becomes very important in cases where you go for organ transplantation. right? So you do this amplitude EEG is confirming that the brain activity is very, very poor and the baby is, clinically is like that. Then you do EEG and then you can refer for organ donation. So I think there are two things that can take from neonate. One is your the cornea, then the other one is the heart valves. The rest of it they don't. Right? Okay. Good. I think we've had some fruitful sessions this morning, and I'm so sorry for the technical glitches, which is not at all in our hands. And I think you're all quite, quite quiet. So we will take a break now. So we'll go for lunch, and then we'll come back rejuvenated with a lot of sugar on board. And then we will start the session exactly at 2 o'clock, please, because we need to do a little catching up, which can be done easily, and we will do that in the workshops. Thank you so much for all your patient listening. Kindly upload all your certificates onto that group.